So I'll introduce a bit myself. I'm a psychiatrist that works in transplant psychiatry now at the Cleveland Clinic, but also seeing inpatient psycho-oncology patients. And I'm an assistant professor of psychiatry at the American University of Beirut, working mostly in psycho-oncology. And my interest in thalassemia started, my talk will be about thalassemia most specifically because that's my clinical experience. I only see adult patients, and I think that's an unmet need in thalassemia. That's my interest started from there. Dr. Professor Ali Tahir, I'm sure you know him, has sent me a patient, and and I was looking at these. I hadn't been familiar with the research on thalassemia treatment at the time. And I know that he was involved in trials looking at these new therapeutics, and we have these new therapeutics prolonging the life of patients with thalassemia. And then I started looking at the data out there, and the literature mostly covers children with thalassemia or SCD, because obviously that's always pediatric onset. So looking at pediatric populations and their psychosocial needs. The literature on adults, especially that the data, the research had been prolonging the lifetime and the lifespan of patients with thalassemia. So you had more people transitioning into adulthood. Looking at the psychiatric needs of adults with thalassemia. And there was really not much, to tell you the truth. When people think about psychiatry, it's most obviously in the chronically ill. People talk about depression, anxiety, coping with the disease, but really when you talk about the neuropsychiatry, it's much more complex in chronic illness, and there hadn't been anyone dissecting this data. So we started. I went to Dr. Tahir with this idea, especially that he has sent me someone with thalassemia who literally had told me, that was my first patient with thalassemia. She had OCD, severe OCD, and she told me, and all our family had thalassemia. She was a thalassemia major patient, actually. And she told me living with thalassemia is much easier than living with OCD, especially with the stigma around mental health. And so we started looking, and really what I think are major issues that are I'll be discussing in my talk as well, because this is about my talk. Major issues that need to be addressed first, not looking at psychosocial needs just at depression and anxiety. It's much more complex than that. We have a real problem in the tools we use for assessing depression and anxiety in the chronically ill. Because if you look at these studies, they're not standardized. And what that means is, and I'll be very brief just to give an example. If I'm jet lagged, right? So I have sleep problems, I have concentration problems, and I have appetite changes. If I answer yes to all these three in the questionnaires they do for depression, I'm automatically depressed. And if you think of any sickler or any thalassemia patient, they might have fatigue and sleep changes and things that are due to the disease that will automatically qualify them as depressed if you look at the regular depression tools we use, while they might not be depressed. So when you look at the literature, very few studies, well, not few now, but I mean, the earlier studies looked at, and thalassemia research in adults is very late in terms of psychiatry. It only started in 2010 or 2008. And so we need more specific tools, but we also need more specific tools to capture other changes that we now know impact the quality of life, which are cognitive changes, things that are not we look at patient-reported outcome, but if you look at the questionnaires that we use for to assess for cognition, the standard measure is a neuropsych assessment by someone who's a PhD or a neuropsychologist. If you are asking patients, I have trouble with concentration, and they are saying yes, like in the PROMIS tool we use, I mean, if you ask me today, I have a problem with concentration. Right? So it's there's a lot of patient bias. So we really have from the get-go inherently a problem with our diagnostic tools in detecting those. The other thing, so as I said, we have to look at other symptoms in psych, like disease-related fatigue, which people look at, disease-related brain fog. Can we talk about thalassemia brain fog? We talk about it in cancer, we talk about it in MS, we talk about it in COVID. We don't talk about it in thalassemia because there are studies that are showing, and I'll talk about this in my talk, there are studies that are showing that it might be as severe in thalassemia intermediate as thalassemia major. It's not related to the disease severity. It's in sickler cells, for example. I don't have experience in sickler cell, but I looked at the studies. It's not completely explained by the vascular infarct or the brain damage caused by the hypercoagulability state. And so we need to understand what the cause is. Is it chronic anemia? Is it sleep problems? And it's not related to depression and anxiety. So there is this special entity subset, a small group that are having pure brain fog that is not related to any of these conditions. But we expect these people to go to work, to be productive, to have a normal life because you know what, you're thalassemia intermediate, you're not that severe, and you started late onset in life, and you don't have vascular infarcts, even though thalassemia intermediate does have vascular infarcts, but they're silent. So are they really silent? So this is what I'll be discussing in my talk. I hope that covers it a bit. I mean, there's a huge unmet need, and I think that should be included in the medication trials we're doing.